Maram Haddad. Maram Haddad is a detected clinical nurse specialist in King Faisal Hospital Research Center in Riyadh, specialized in oncology and bone marrow transplant. Maram received a prestigious DICE award in 2022, and she holds multiple certification in process improvement, patient experience, chemotherapy administration, and palliative care. She's commitment to advancing nursing practice and improve patient outcome across the complex care setting. She will present for us the enhanced transplant rate in a sickle cell disease patient. Welcome, Ms. Maram, mic for you.
Thank you so much. Thank you much. Thank you so much, Suha. Appreciated. Good afternoon, everyone. It's my pleasure to be here. I would like to thank the organizational committee for their invitation to show our project, what we do with sickle cell disease patients. It's have significant impact to affect the transplant rate for our patient. So hopefully you have a benefit from our presentations. Okay, let's start with looking for and understanding the landscape of sickle cell disease patient here in Saudi Arabia. We know the sickle cell disease patient is a inherited disease who affect the hemoglobin S mutation, which causes chronic hemolytic anemia, vaso-occlusive crisis, infection, and sometimes it can lead to organ damage. طبعا incident in Saudi Arabia, we know it's very high incident in Saudi Arabia because it's considered of the most common hemoglobinopathy disease in Saudi Arabia, which really it's make burden because we have higher career rate. So we have made big population, and most of them, they are really young. So we want to focus on that group because we know we don't have attention in that group really from other services. We know it's really burden in our country, in the Saudi Arabia. So, okay, we say we are in highly demand, so always the highly demand, it means there is many of challenges. So we have many challenges how we transfer or do the transplant rate for sickle cell disease patient. With the challenge we face, actually, always we have imbalance between the demand and the capacity. Always we are facing, we don't have capacity to accommodate this huge number of patients. So, we have a long waiting list. I don't know if the other hospitals do the same. Since I joined them, I started to log out all the patients to put them in the waiting list. We have more than 500 patients waiting list to be transplanted. Scheduling and constraints, طبعاً we know sometimes we don't have donor, some patients they have many donors, and the pre-transplant workup time. Really, we are facing problem with the pre-transplant workup time. Why? Because we have a limited time, and the patients, they have I will not say non-compliance, but when you book the patient for workup or PFT or some workup you need it for dental before you start, the patient will have vaso-occlusive crisis and he will be going to emergency to take his painkiller and his non-compliance. So that it make the time for we are doing the workup is really prolonged. More than like when you have a plastic anemia, when we transplant a plastic anemia within 1 to 2 weeks or the workup is done for them. But the compliance of that patient is really take more time with the workup. So we need also careful priorities for that patient. For some patient, we give them priority. Why? We have multi-acute chest syndrome, multi-admissions. They are really suffering a lot, sometimes admission ICU. So that patient, we give them priority to save them life. Also the cost. We know also when you do donor for workup, we already have a cost in the hospital. Our key messages to increase the sickle cell disease transplant demand require efficient priority, capacity planning, and streamline the pathway for the transplant. So, look like now where is the problem? We want to look where is the bottleneck. If we can focus about our problem is minimum hospital stay. We need higher transplant rate because we know we have a 500 patient waiting. So what we do, actually before we admitting a patient in the inpatient for 3 to 4 days just to do the line insertion, outpatient, RBC exchange in inpatient, then we'll start the patient conditioning. So what we do, طبعا that one is lead to prolonged hospital stay and higher cost على الhospital. So what we think about, we need to shift the modules as outpatient modules. So we know some hospitals, they are doing that. So we are facing no one to do this one for sickle cell disease patient because it's more safer to transplant them as an outpatient. So the outpatient modules, we want to discharge the patient early as well to be following in the BMT drop-in. So to put that, we want to put a smart aims to help us to achieve that goal we put. So we put to decrease the average length of stay for patient in inpatient, for eligible matched sibling donor. When we have a data and we collect the data, we find a patient's length of stay in inpatient 42 days. Imagine each patient, we transplant him and we admit him, he stay in hospital for 42 days. It's really so much long time and we don't want to make it, and we put target to be at 29 days. So, and we started that one in Q3 of 2025, and we want to sustain for improvement. Any project or anything or any idea, you want to do it, you want a team. You want a strong team, multidisciplinary team to achieve your project. So really, we are building our team who are really multidisciplinary, from nurse practitioner, from physician to modify our protocol. And we have also a coordinator, we have a nurses, we have a clinical pharmacist who help us to achieve that. So let's have a look for our the process when we admit the patient. In day 1, in level 19, day 2, we do the line insertion. Day 3, we do our RBC exchange. Day 4, we start the chemotherapy. Until the patient will reach day 42, patient will be discharged and having twice weekly appointment until reach 100-day post-transplant. See, it's so much longer process. It's so heavy on the patient, and really it's take long time and slow. Okay. If you want to achieve anything, we do the structural improvement methodology. We use that Institute Healthcare improvement modules to achieve our sustainable goal plan. So when we think, we analyze our problem, we analyze the drivers. What's the driver they cause to achieve our aims? What's the driver? First is insufficient pre-BMT process coordinator. So what we do as an intervention, coordinator will be assigned to do the line insertion outpatient, the RBC exchange will be done outpatient, the package ready with the roadmap, with everything to the inpatient upon admission. When the patient will be admitted directly, we'll start in chemotherapy. So we see 3 to 4 days minimum. So prolonged recovery post-chemotherapy, the patient can stay a long time in the inpatient after he receiving the chemotherapy. So to enhance that one, we measure hemoglobin S in day 0. If the hemoglobin S is good, we monitor the ANC and the platelet. If the platelet more than 20 and the ANC is more than 1 for 3 consequent days, we add GCSF in day +7. So this modified protocol we use as a standard protocol after then. So the patient will be easily fast recovery after the chemotherapy. So underutilization of the nurse practitioner in outpatient setting, we provide appointment before twice weekly. No, now if we discharge the patient early, we need to utilize the outpatient setting. So we book the patient's daily appointment with the nurse practitioner who cover post-BMT drop-in to see if the patient will need to be seen daily, they will give appointment daily with the consult of the MD. If the patient will be shifted twice weekly, they will shift the patient twice weekly up onto the patient condition. So great, let's have a look for our new process after we apply our intervention. Now, most of them is done as outpatient. We insert a line as outpatient. If the patient have a good pain, we insert a line in the ICU. If the patient doesn't have pain, if he have a vein, we will do the RBC exchange via his vein. When we admit the patient, if he have line, we already going for starting chemotherapy directly. If the patient doesn't have line, we insert line and we started chemotherapy in the same day. But most of the patients, they will not have a vein and they will go for the second way. So in the outpatient setting, when we discharge the patient earlier, we give daily appointment with the nurse practitioner until we can shift them to twice weekly, later until 100 days. So let's have a look for our data. When we put our data, we say our outcome measures, we have a process measures. If we have outcome measures, we put the target to reach 29 days. طبعا alhamdulillah, we reached 23, 24. Some of the patients, they have really early engraftment. Okay, our number, our process major numbers, we targeted to reach 70 transplant rate that year, 2025. Sorry. Okay. So our outcome, when I would tell you, it's go beyond the average length of stay really, because we increase also bed capacity, we decrease the cost, we increase the patient also experience our satisfactions, and really it's remarkable if you can see from our data when we go to November 2024, average length of stay for them is 45 days. And when we start to implement the ideas in June 2025, it's decreased from 32, 33, we reach also 26 in October. This is, I'm telling to you, is the average. It means يعني some of patients, we discharge them in 20, sometimes 18 days. But when I tell average, because some of the patients, they have many complications, some GVHD, so they take long time in the hospital stay. But this is average, which is mean it's very good. Okay. This is, I'm telling to you, our project impact. See, it's really remarkable, the outcome, because when we go before, in 2023, we transplant only 20 patients sickle cell disease. In 2024, we transplant 40 patients sickle cell disease patients. In 2025, we reached 72, which is great. Yani it means we started just from the end of the year to implement that, and really the number is remarkable. Okay. If you want to sustain or make this success continuous, you want to put a monitoring method plan. So really we put mention, and always our data is monitored and mentioned by BMT office team. We also sharing our quarterly report in BMT leadership meeting. A sickle cell disease waiting list is still, mashallah, it's moving now. This is one of the impact too. And our list started to be moved, and it's really good for satisfying the patient when they will come to ask you, what's my number? And last year, my 150, your number is now 70, which is make them sense like their number is coming to do the transplant. Okay. So the sustainability is the key. Always, if you want to do anything, you want to sustain it. For us, we always look for improvement. We know this type of patient, they don't have too much focus on them, but really they are really very demanding patient. They need to look for their priority to do the transplant for them. So our modified protocol with adding GCSF now is a standard protocol. We use it for all patients. More and more patients, they are recruited in that project. We conduct a monthly meeting for resolve any clarity. We share our achievement in BMT monthly multidisciplinary meeting. We enforce also the new process among all physicians to sustain that plan. So our thinking now, inshallah, we will expand the project to do all the chemotherapy as outpatient. We are struggling with some issues, but this year, inshallah, we expect it to increase their numbers more than 120 to sustain this process and make this project is really remarkable. So in that, I will to be end, and I will thank all of you for your intention, for your collaborations. Really, that patients need to be focused on, because really you are not giving only an improvement for their process for transplant. We are giving and transforming their future, really, because this patient really, we are doing now research about the quality of life for that patient is really interesting when you saw how much you change their life. From hospitalization, they stay in the hospital, coming for a crisis many times, to normal people, you can see them, they are not coming for their follow-up, because really they don't want to come to the hospital. So thank you so much. It's open for any questions.
Thank you so much, Maram, for nice presentation. Any question? Any? I want to ask you, when you do RBC exchange how long prior the conditioning?
Actually, we do hemoglobin S. We measure hemoglobin S. Is hemoglobin S less than 30? We don't do RBC exchange. But most of our sickle cell disease patients, hemoglobin S more than 80. So by default, we already book patient for RBC exchange 1 day before starting the conditioning. To be sure, in hemoglobin S is 20. Really, we are measuring, because some of the physicians, they will tell me, I will write the conditioning until I will see in the system hemoglobin S is less than 20. I prove all of them. When we do the exchange, really, it's decreased to 20.
Dramatically.
Yeah, dramatically after the exchange.
Do you increase the hydroxyurea 8 weeks prior transplant?
Actually, we give the same dose of hydroxyurea, but some of the physicians, they give sometimes steroid, prednisolone, 2 weeks prior to the transplant. It's not a protocol of all physicians, but some of the physicians, they give two-week prednisolone before.
Ah, okay. Because, and I think you are giving myeloablative condition, right?
Yeah, we give ATG with fludarabine, busulfan.
Yes.
Yeah, and methotrexate.
Because our practice is a little bit changed because we are not giving myeloablative, we give non-myeloablative because that we increase the hydroxyurea. Steroid, we give it if the patient have alloimmunization in RBC.
Yeah.
We do this actually. We give if the patient have alloimmunization or and high against especially the donor. At the time we give steroid and we give rituximab actually. Any questions?
No questions because
No.
I finished
Thank you
early.
so much. Appreciate.
Thank you.